Good morning, everyone. Welcome to the viewing and listening audience to the 22nd meeting of the Joint Select Committee on Social Services and Public Administration. This is the committee's third public hearing with stakeholders pursuant to its inquiry into Trinidad and Tobago's response and responses to the prevalence of non-communicable diseases and other issues concerning the delivery of healthcare services in the country. Members of the public are invited to submit their comments and/or questions on the Parliament's social media platforms, including YouTube, ParlView, or via Facebook and Twitter. We're happy to have with us stakeholders from the Ministry of Health, including the Ministry of Health itself, the North West Regional Health Authority, the North Central Regional Health Authority, the Eastern Regional Health Authority, and the South West Regional Health Authority. At this time, I'd like to announce that the Tobago Regional Health Authority was invited to attend this meeting. However, the committee was informed that the authority was unable to participate due to administrative challenges. At this time, I'd like to invite members of this committee to introduce themselves, starting on my right with Member Naked.
Good morning. Nice of all of you to be here. Looking forward to a productive session.
Penelope Beckles, member. Yes, let me join with my colleague, the Honourable Senator David Naked, in welcoming everyone here, and we're looking forward to a very productive session. Thank you.
President, good morning, Chairman, members, and those of you joining us. Member Mohit, looking forward to a productive session with all of you.
Thank you. I'm the committee's chairman, Paul Richards. I'd like to invite the members of the stakeholder groups to introduce themselves and their teams, starting with the Ministry of Health, please.
Thank you. Good morning, members. As committee chairman, Asif Ali, Permanent Secretary of the Ministry of Health.
Good morning, Chair and committee members. Anthony Blake, Chief Executive Officer at the Northwest Regional Health Authority.
Good morning, Chair and members. I'm Dr. Brian Amor, the Chief Executive Officer for the Southwest Regional Health Authority.
Good morning, members and Chair. My name is Stacey Thomas-Lewis. I'm the Chief Operating Officer, Acting CEO of the North Central Regional Health Authority.
Pleasant morning, members. I am Angelina Rabasad-Pierre, Acting Chief Executive Officer at the Eastern Regional Health Authority.
Thank you all, and we appreciate all your good selves and your teams being here with us. Just to give some context, on November 15th, 2023, the committee met with the management team of the Ministry of Health and the regional health authorities to discuss the state's strategies in combating non-communicable diseases. As you know, non-communicable diseases are among the biggest challenges facing the world, and certainly Trinidad and Tobago is no exception, with what I believe to be as much as 60% of mortalities being attributed to NCDs in some way or the other. Following the public hearing, the committee held 5 town hall meetings, and I'd like to really publicly thank those who hosted us in the Parliament building, at San Fernando at City Hall, in Central Trinidad, in Arima, and most recently last week Thursday in Tobago. The first town hall meeting was held on the Parliament's complex on Wednesday, November 29th, 2023. The second at the San Fernando City Corporation on Thursday, January 18th, 2024. The third at the Center Point Mall in Chaguanas on Thursday, March 7th, 2024, followed by Arima on Thursday, April 25th, 2024, and last week Thursday in Scarborough, Tobago, Thursday the 13th of June, 2024. A second public hearing was convened for Wednesday, March 20th, 2024, with the Diabetes Association of Trinidad and Tobago, the Trinidad and Tobago Heart Foundation, and the Trinidad and Tobago Cancer Society. Following the committee's extensive consultations with the public and members of stakeholder groups, the committee thought it prudent and important to convene this meeting to allow the Ministry of Health and the CEOs of the regional health authorities and their colleagues the opportunity to respond to some of the major issues and, in some cases, recommendations which were highlighted by members of the public and the various stakeholders organizations. We'd like to publicly also thank all the people who came out to those town hall meetings. We really appreciate them coming out and sharing their experiences, good and bad, with us at those exchanges. At this time, I'd like to invite the leads of the teams with us to deliver opening brief remarks, hopefully not extended past 2 minutes, starting with the PS Ministry of Health, Mr. Asif Ali.
Thank you, Chair.
Is the mic on?
There's no plateau. No.
Yes, thank you. It seems to have gone off again. Could we exchange it with another mic? We just charged the Ministry of Health for it.
I guess we'll share this one.
Yeah, that's better. Thank you.
Okay, fine. The Ministry of Health is the national authority charged with oversight over the national health system and plays a central role in ensuring that the provision of health services conforms to the principles of universal health coverage. As it relates to non-communicable diseases, NCDs, our key strategic priority areas and program activities are focused on the personal health and wellness of our population and strengthening our support systems to our clients. Chair and members, I take this opportunity to reaffirm the commitment of the Ministry of Health and the RHAs in the provision of health services and look forward to today's proceedings to allow us to further share information with respect to the programs and services for the prevention, treatment, and care of NCDs. Thank you.
Thank you, Mr. Ali. Can we go next to the Chief Operating Officer of the North Central Regional Health Authority, Mrs. Stacey Thomas-Lewis. Microphone on?
Oh, sorry.
Thank you.
Okay, sorry. Good morning, Chair and committee members. My name is Stacey Thomas-Lewis, representing NCRHA this morning with our General Manager, Dr. Abdul Hamid, and our Medical Chief of Staff, Dr. Kamani White. We are here to highlight all our improvements and the activities associated with our battle against the NCD with the instructions and guidance under the Ministry of Health. So we trust that all the questions and comments posed to us will be able to respond in a positive and productive manner. Thank you.
Thank you. Can we go next to Mrs. Angelina Rampersad-Pierre, the CEO, Eastern Regional Health Authority?
Thank you, Chair. With me today is Dr. Rajiv Bagalu, our Medical Director representing Secondary Care Services, Dr. Jamila Augustine, our County Medical Officer of Health representing our Primary Healthcare Services. The Eastern RH is very excited to be here this morning to participate in this session. We look forward to answering all the questions posed by the members and chair, as well as being able to inform the public of the services and our improvements at the Eastern RHA.
Thank you. Next, CEO of the Southwest Regional Health Authority, Dr. Brian Amor.
Good morning again, Chair and members. The Southwest Regional Health Authority is pleased to be here in partnership with our colleague RHAs and the Ministry of Health and with the general population at large. Accompanying as part of the Southwest delegation today is our General Manager, Policy Planning and Research, Mrs. Michelle Murray Lafoucade, as well as our General Manager, Nursing, Mrs. Rachel Jardine Burkett. We too look forward to answer all questions in a matter of accountability to the public, and we are very conscious that we're all here for the health and well-being of the nation at large. Thank you.
Thank you so much to you all. Just a bit of housekeeping. We'll remind both committee members and officials to direct their questions. Oh, I'm sorry. Can we go to Mr. Anthony Blake, please, CEO of the Northwest Regional Health Authority? My apologies. Sorry.
No problem, Dr. Richard. So morning to you again, and morning to the members of the committee. And just like my colleagues here and the PS, we are proud of the Northwest Regional Health Authority to be here because accountability is important to us and to our colleagues here. With me today, I have Dr. Keisha Gangaram, our Director of Health, I also have Dr. Kellyanne Mike, Director of the National Cancer Center of Trinidad and Tobago, and I also have Dr. Keegan Bagan, our GM Primary Care. Thanks very much.
Thank you all. Certainly, with everyone here, including the CMO, we know we have the prominent stakeholders and figures in the healthcare system in Trinidad. Of course, Tobago could not be with us for administrative reasons, and we really hope to be able to identify through you some of the challenges you are having, because our interfaces with the public have been very eye-opening and elucidating to what they're experiencing on a day-to-day basis in terms of interfacing with the healthcare system in Trinidad and Tobago. And as you well know, because you're the medical healthcare professionals, when people are ill or their families are ill, it is a crisis in their families, and there is a response that they have internally, psychologically and physically, and they are under duress under those moments, and they go to the public healthcare system in particular to get redress in a particular way. There's been good news, and there's been very, very not so good news. So we hope to be able to share some of the experiences with you that the public has been able to tell to us directly. In terms of just housekeeping, we ask members and officials to direct their questions through the chair. Members are kindly asked to activate their microphone on their devices in front of them when you're acknowledged by the chair, and turn them off when you've concluded your contribution, and we'll proceed accordingly. In terms of our interfaces with the public, the issues that have arisen fall into some general categories, including delayed appointment times, delayed service times, equipment shortages, access to treatment, access to medication in some instances, focused on CDAP, and inside of the medical healthcare system. Also, they've had issues in patient record management, and also, last but by no means least, in particular reference to NCDs and proactivity and being proactive and preventative awareness and education programs. And it was quite interesting to hear some circumstances where persons went in what they considered emergency situations. And I know there's a triage process in the hospitals, but in one case in particular, a young woman went in with severe breathing difficulties and was forced to wait. In another instance, a gentleman and his wife both had heart conditions, and after the initial intake were given a year appointment to follow up, and the gentleman's wife passed, unfortunately. And these are the kinds of stories that we've heard, in addition to some good news. So I think the public is expecting a lot in terms of responses and recommendations on how they will be implemented. And I want to start by asking the PS and the CMO a question about and there's a difference between clinical proficiency with the medical professionals and administration and management. And of course, they work together, you can correct me if I'm wrong, to complement an efficiently operating healthcare system. And in doing some research before coming here, many of the papers I've read indicated that among the biggest challenges facing healthcare sectors in North America, in the UK, in the NHS in the UK, and across the world is the management and administration of healthcare services across various sectors. So could the PS and then the CMO indicate if there are challenges in administration and management in the various RHAs in the country, and what those challenges are that you face on a daily basis in delivering healthcare services to the people of Trinidad and Tobago?
So, thank you, Chair. Maybe I could start. So at the level of the ministry, we do have the appropriately resourced persons to provide that sort of administrative support, oversight, guidance, and technical guidance also to the RHAs. I would let the respective CEOs speak to what exists at their various RHAs.
Sure. At the Southwest Regional Health Authority, there is an organizational top structure, which starts with the CEO and the executive management team. And then we have technical heads of departments in different spheres. The core business of the industry is medical and nursing. So we do have core clinical executives there, and we do have a demarcation into secondary care and primary care services, as well as outreach services. From a health systems approach, apart from the core services, you do have other spheres of administration, human resource, finance, ICT, corporate communications, particularly quality as well, and risk management services, to name a few. So organizations like us, we're guided by a strategic plan, which in turn is guided from the Ministries of Health strategic plan, and they in turn are guided by the government's agenda. So with a strategic plan, vision and mission, and with the goals and objectives, then we implement and architecture policies and programs and service delivery models to manage the healthcare system. It may sound armchair, but those documents and reports are living documents. So we get dynamic feedback from patients, staff, visitors alike, and then we factor that into a monitoring and evaluation framework that then impacts on how we interpret the results and meet the needs of the patients at core. So that is a snapshot as to how the management and administration works at Southwest.
I'm glad, Dr. Armour, you mentioned it was an armchair response, because I could find that in a book and a document, and that's great. It's wonderful. That is the prescribed policy and procedure and strategies. But what I want to get from you as to the question, because what we have gotten is a different level of feedback from the public. That may be all well and good as documented, but that's not the feedback we got in terms of if that's operating efficiently because of the delays and the challenges. So the question again is, are there challenges? And what are those challenges? Because clearly, when you walk into the hospitals, the RHAs, particularly the larger hospitals, you see scores of people waiting, hours, 12 and 10 and 16 hours. So what I want from you is clearly that can't be efficient operation. Clearly there have to be challenges which are the catalyst for those massive delays in people who are in crisis in many cases. What are the challenges you are experiencing in management and administration that may be causing these kinds of issues? So the overall policy document is great, but when the public is looking on, that is not the experiences in a lot of cases, in many, many cases. So they want to hear what we're giving you the opportunity to tell us what your challenges are.
Duly noted, Chair. The system is not perfect, but there are a balanced scorecard of successes and challenges. One of the main ways in which we monitor successes and challenges is through management of quality indicators, for which we have client feedback system reports. We measure the things that were mentioned in the public consultations, wait times, delays for surgeries and things like that. So therefore, from that, the challenges, when they present to us, then we have to have systems in place to use the resources that we do have in order to be efficient, to at least ameliorate and at best solve the problems that we do have in the sector. So it's a monitoring and evaluation framework. Our quality department, from the executive arm to the front-end arm, they look at the impact of the service delivery models and programs, and based on the feedback that we get, then we do a resource allocation or reallocation approach in order to solve. We work in a resource-constrained context, so we are always asked upon to be as efficient as we can. Everybody would like more resources, but the resources, we use it as efficiently as we can at this point.
So Blake, let me be more direct with my question, because that answer kind of frustrated me. And I'm not saying you're inaccurate, you know. Do you have equipment challenges? Do you have staffing issues? Do you have personnel management, HR issues that provide significant challenges in you effectively delivering healthcare at the Northwest Regional Health Authority directly?
Sure, Dr. Richards. So I will attempt to qualify some of what you said. So let's start with the health administration first. So when we look at healthcare, as my colleague said, yes, you have a lot of clinical professionals, but managing an RHA is similar to managing any different ministry. So when you come out of the operating theater and so on, you have to manage for success. And in some of the ways that Brian would have said, one of the things we've seen at the Northwest Regional Health Authorities, a lot of the middle management were not really trained for management. So you may have been a nurse all your life and then graduated now to become a nurse manager. But what is the pathway for that? You may have been a doctor and then now you become the head of clinical operations and so on, but not being trained for management. So one of the things you would have seen, for instance, on our social media, is that we'd have partnered, signed an MOU with the University of Trinidad and Tobago to train our clinical professionals in management. We've actually done an entire cohort last year. That cohort would have graduated 2 months ago, and we're starting a new cohort this month specifically to train clinical professionals in the areas of middle management, realizing that there's not a depth management knowledge within the clinical professional area. The next thing we look at is resource allocation. When you look at the type of human resource coming through the RHA, so we always hear about nursing shortages, and every RHA here could bear me out. We always have shortages in that specific area, and they will tell you that nurses are really the lifeblood of the organization, but you're facing several factors there. You're looking at the pull from the US. You yourself, Dr. Richard, spoke about in your research. You looked at the NHS and so on, and you would see the large difficulty there and all at this point in time having retaining nurses. The same thing is going on in Canada. The same thing is going on in the States. So you have all these recruitment agencies coming to Trinidad and Tobago now to recruit our very qualified nurses here. So one of the issues are that nationally the pool of available nurses is not sufficient to give us the level of nurse to patient ratio that we would like. What we've done, we've been working with the Ministry of Health and the International Desk and the Ministry of Foreign Affairs to also look at recruitment of foreign nurses. We're also looking at our retention strategies for local nurses. We're currently doing a permanency exercise at the Northwest Regional Health Authority. We also, with the coming of the central block, we have approximately 100 nurses on full-time specialist training now, so we're investing in the training and education of our nurses, also helping to fix that issue of retention. The next thing you spoke about was equipment. Yes, you have a difficulty with equipment, and I'll contextualize it. Port of Spain, for example, has 2 CT machines now. There was a time we had 1 CT machine, and thankfully we got another one this year. The 1 CT machine, based on the need, right? I am a civil engineer, and I could tell you, you will get, when you get a piece of equipment in the public service, the manufacturer will say to you, the running hours for this piece of equipment supposed to run 6 hours for the day, maximum. But because of the patient load on a CT machine, on a dialysis machine, other types of machine, you may find that 1 piece of machine, example like a CT, being on for 24 hours in the public healthcare system. So the ability to plan maintenance from the engineering staff based on the need from the public is much more difficult, because we would have looked at running hours and be able to say, you know what, we will change a CT tube every 6 months and order a tube every 6 months. But because of the need in public health, it is much more difficult to predict. The other thing is, because we don't manufacture these things locally, and because of the challenges with foreign exchange, a lot of the local suppliers are not stocking spare parts in Trinidad. They rather keep their foreign exchange than have spare parts on the shelf waiting for the RHA to order. So a lot of times, if you have a breakdown in a piece of equipment, what will happen, the manufacturer rep locally may say to you, it may take 4 weeks, 3 weeks, and so on to get the specific part in the country. Remember, none of these dealerships would really stock other than simple maintenance part. Once is a more complex part is something that we have to go out of the country for, and it usually takes some time, and obviously that will cause some downtime with us.
Thank you. Just before I go to my colleague, Member Mohit, PS and CMO, could you give us a sense of what the nurse-to-patient ratio is presently in Trinidad and Tobago, and what best practice internationally is, and how we compare?
Chair, so I'll let CMO speak to what is the best practice international ratio, but it would vary between RHAs. Obviously, each RHA would have a different nurse-to-patient ratio. Is not the same across the board, so that varies by RHA.
Yep, so even between RHAs, it varies between types of settings. For example, in an ICU setting, you expect that you have 1-to-1 or 1-to-2 ratios for nursing. In a general ward where you have some ambulant patients, you'll find that will change over time. So it does vary not only within RHAs, but at the individual setting, and we can provide that in writing as it relates to the different types of settings to the committee, if that is acceptable.
Are we along, and I understand what you said with the different types of nursing situations or needs, but given what you know of the RHAs, are there RHAs that are vulnerable because of the nurse-to-patient ratios, and which RHAs would those be, and those that are more comparable to international best practices in any of the categories, including ICU nurses or general practice nurses?
I wouldn't say that there's a specific RHA that's vulnerable. I'll say there's a specific setting, and CEO Blake started the conversation about being a small island developing state and the issue of retention and engagement, even on the first instance, of subspecialists in both nursing and medical care is always a challenge for us. So out of that, we find that for certain specific areas, there's always a challenge. For nursing, for example, in terms of ICU, retaining ICU trained nurses is a difficult area for not only us, for other small island developing states like us. And it really relates to the packages that we offer, conditions of work, and all the others that have gone before in terms of discussion. But I think just mooring us back to the NCD epidemic a little further, the waiting times, especially in an A&E setting, is related to the large prevalence of NCDs in Trinidad and Tobago. We had significant discussion at the last meeting related to the work that the ministry is doing to try to move towards prevention. Moving towards prevention is not something that will cure the ills of the system overnight. It is something that takes 5 to 10 years to be in process. In the meantime, we have to try to do the engagement, as CEO has said, to increase the number of staff that we have at the front end, bearing the challenges. So I would say, as you asked in the outset, the challenges that we have is that we continue to have an NCD epidemic, and this is looking at the national level. And our focus in the ministry is really trying to deal with that at the primary care level through prevention. And hence we have our director of NCDs with us today as well. We also have the challenge that Trinidad and Tobago continues to try to offer universal access to care as a free system to the public in the public health, in the public system, offering free universal access to care in the context of also offering some of this free universal access, bearing in mind we have a non-national policy which speaks to access of public health diseases, immunization, and acute emergencies for non-nationals as well. You have a growing population that is seeking public health care. So just to contextualize a little bit the challenges that we're seeing from the policy level, retention, NCD epidemic, and of course, having universal access with a finite purse.
Thank you. Member Mohit.
Just for my own edification, just crystallize it for me, based on what has been submitted so far. We have a problem with the nursing ratio. Our nurses we are short-staffed basically. Correct me if I'm wrong, that's what I'm hearing. A lot of nurses, there's a nursing drain, which I know personally from family, going abroad and so.
So I wouldn't say there's a general short staff. What we said in the specific areas, there are short staff of certain types of nurses. General nursing, for example, and the nurses among us can elaborate a little further, and I can speak to my CNO, Chief Nursing Officer, and get figures as to which categories are actually short staff. So we could submit that to the committee.
So just a question, Mr. Parson. Has anything been put in place to cater to that kind of specialization that you're referring to as
so what we have done through the ministry is through the International Cooperation Desk and bilateral arrangements with other countries. As you know, there's an existing arrangement that we have with Cuba, a long-standing arrangement from a number of years. So nurses continue to be brought in through that agreement. We are trying to look at other bilateral agreements that can be put in place, government to government, to do similar from other territories as well, while we do training, which is an ongoing process for the subspecialties. So it's training of our local nurses in the interim, and while that before matriculation and before completion, we're trying to buttress that with international support as well.
And how has that been going? You can give us some indication?
Well, I think without the international support, it would be difficult to maintain the services that we have. So I mean, really, I think that cooperation has been very good towards Trinidad, and we want to see that grow from other territories.
Thank you, Member Mohit.
Thank you very much, Mr. Chairman. Mr. Chairman, I'm listening to the responses, and I totally understand what is a correct CEO's answer. But I think what general public is looking forward to hear from this meeting is that of what exactly is being done to improve the healthcare system. So, Dr. Amor, I listened carefully in terms of your monitoring and evaluation, your resource constraints, etc. How would you usually deal with it? But arising out of these town hall meetings, we would have had specific issues being vented to the committee, that of long wait times. So, for instance, what I would like to hear from you today is what exactly the RHAs are doing to deal with patient volumes, given that of the public outcry. In terms of your equipment shortages, which you mentioned, we would have had persons saying to us that they are forced to seek private healthcare due to the issues they face in the public institutions, due to shortages of equipment, etc. What exactly is being done to address the shortage of equipment? How are you approaching your PS? How are you dealing with draft estimates for the next financial year, etc.? What exactly is being done as it relates to your patient volume, your shortages of equipment? Yes, your monitoring and evaluation and your resource constraints explanation, it sounds good. That's normal procedure. But in terms of hearing these issues coming from members of the public at these town hall meetings, it's not by coincidence. It's each and every town hall meeting that we attended, persons had these issues ventilated. So can you please explain from your various RHAs what exactly is being done as it relates to these delayed appointment times, these shortages of equipment?
If I may, before the CEO starts, so just taking up on Member Mohit's question, I'm looking at 3 areas, as you said: possible or perceived equipment shortages, delayed appointment times or wait times for appointments at the clinics, and I know it was mentioned also within your A&E departments, they also wait times, treatment times within A&E. So I'll let the CEOs, respective CEOs, speak to what are we doing in terms of those 3 areas, what strategies they have in place to address those things. But just bearing in context what CMO spoke about the contextualizing where we are in terms of increased demand, for example, at our clinics and to a lesser degree at our emergency departments because of NCDs. You have more persons coming in. So while, as CMO said, we're treating with health promotion and educating and empowering the public, that will take some time. Those persons who unfortunately have diabetes, have hypertension, that's not helping them so much right now. It will help those persons prevent them from getting NCDs. So we have to treat with the current situation as we go forward.
Okay, thanks for the question. Dealing with major equipment shortages, we have major medical equipment. In Southwest View, they largely function well. We have an age MRI that has had challenges, intermittent challenges with downtime, but we are working with the Ministry of Health through the PSIP and administrative systems to attempt to source a new MRI, but the current MRI is functional. We also collaborate with North Central Regional Health Authority within the last couple of weeks in order to deal with our outpatient persons who have to get MRI services at North Central, while we reserve the warded patients to access our MRI services that are currently functional. Our CT scans, we have 2 CT scans. We were down for a CT scan for about 4 to 5 months due to the fact that the one in the ED was aged. And as of yesterday, we have supplied, installed, and commissioned 120th slice CT scan at the Southwest Regional Health Authority San Fernando Department. So in terms of what was intervening in the interim is that we had 1 CT that was managing ED cases coming through the emergency department as well as the outpatient clinic. But with the commissioning of this new CT scan, we back up to 2 CT scans, and that also excludes the CT scan services available at the Point Fortin Hospital. We do have X-rays, ultrasounds, and other equipment that has a certain redundancy factor, as we call it. So if one breaks down, we can rely on another machine in the interim, and that is really through our hospital EDs and our district health facilities. How that translates to wait times are that for example, in the Point Fortin Hospital, you can walk in and get x-rays same day, you can get ultrasound same day. In the outpatient clinics in San Fernando General Hospital, from the data metrics that I do have, you generally can get the appointments within a couple of weeks to get those tests done. Those are basic tests. MRIs, we do have the relative backlog around 8 to 9 months, but as I said, we are addressing that, working with North Central Regional Health Authority. In terms of the waiting times, we do monitor very closely.
How does an 8 to 9 waiting time affect a patient's prognosis?
Largely it will not. So we'll have persons who have to have what we call elective procedures where they have disabilities or ailments that can be best corrected with surgery, but it is not life or limb threatening, but it will improve the quality of life. So the medical and nursing personnel, they will collaborate and we would have a prioritized list. I did say that for persons on the ward, we are maintaining those who need urgent MRIs, whether it is for urgent surgeries or urgent procedures, that still is done. And we are collaborating with the North Central Regional Health Authority within recent times to address that backlog. But out of all the equipment, that's the only one that we face challenges with at this point in time, but that will be resolved.
Mrs. Ramprasad Peer.
Thank you, Chair. So at the Eastern RHA, just to give some context, we cover 1/3 slice of the island. That alone in itself is a challenge because we serve Matlot all the way up in the north, Guayari, Bishan, Brothers Road. We are also unique in that we have a lot of tourists come into our area as well. So that speaks to the patient volume sometimes and the geographical spread that some of our patients have to traverse in order to get services. So that in itself is a challenge and can also be linked to the patient care in terms of them coming down to access. We do have 16 primary healthcare facilities in the Eastern RHA with an A&E in Toco, Rio Claro, and Mayaro. So that allows us to bring some of the secondary care services closer to the population. Of course, major secondary healthcare services, they will have to traverse to Sangre Grande for that. In terms of equipment shortages at the Eastern RHA, we do not have some of the large equipment like MRI, for example, that will come on stream when we fully operationalize our new Sangre Grande hospital. So we would depend on a partnership with our other RHAs to serve the population. So of course we will be impacted by wait times because our patients are in a pool with the national public where we partner with our other RHAs. In terms of our equipment management, in terms of what we do,
just to get a sense, when your patients from Eastern RHA are referred to your partner RHAs who already have delays, how does that impact their time now? Because it seems to me that what Dr. Armour said and Mr. Blake said is that they have challenges because they also have volume.
Yes.
So if you're transferring or referring your patients now for RHA, for MRIs on top of that, what happens to their appointments?
All right. And there is also prioritization from the clinical perspective so that when the MRIs are referred and the clinicians review, they will know the severity and the urgency of the cases that is coming their way. So yes, it will add to the volume of the other RHAs, but clinical prioritization will occur so that clients who are very urgent, example, oncology patients, will be seen a lot faster than someone who may be looking at something a little less severe. So it does add to the pool.
What if I told you earlier on this morning, and this is to the general pool before us, that while that may be so in principle, and it may be happening, I can't doubt that, I have no evidence to say it doesn't. Just this morning I heard about a situation where a gentleman had a very bad headache, went to St. James, and this is not necessarily for you, but generally, went to St. James. The initial examination saw him seeming to have a brain bleed. So he was referred to Port of Spain, and he had to wait 24 hours to get a scan. When he got there, they told him, well, St. James didn't tell me nothing. So he went there expecting to have his documentation in place because he was referred by a sister establishment, but had to wait 24 hours with a brain bleed. And it's only when he called a relative in the system to intervene, he got services 24 hours later. So while in documentation, it may be so. In practice, there seems to be gaps. In some instances, communication. How do we respond to that? How do we fix that? Is that something that you acknowledge may be happening?
So we do have a very good partnership with the RHAs. We have our quality department who will ensure follow-ups in terms of the referrals. Of course, for inpatient services, it's a lot easier because that person is going down to get it, coming back up to the ward. For outpatient services, we monitor through our quality system as well as our ongoing outpatient clinics. So when we know a patient has to come back for a clinic, the file is checked and so on, and if the MRI is not in there, we have follow-ups with the respective RHAs on it. Right? Not saying that we may not have hiccups in between, but that is the system that we have in place. And of course, if there are delays and patients reach out to us, we ensure through our quality department that we monitor throughout to get the necessary reporting from the MRIs or whatever testing we send outside.
Mrs. Thomas Lewis.
Good morning, Chair and Committee again. As it relates to the interaction at our accident and emergency, the NCRHA has clinical ambassadors, clinical liaison officers, and emergency medical technicians. So as soon as a patient presents themselves, they are interacted with either one of those positions, and clinical priority is given. We have a 98% uptime as it relates to our medical equipment. We undergo rigorous planned preventive maintenance on all our medical equipment. So for the past 5 years, we've been able to receive medical equipment ranging from infusion pumps, CT machine, MRI. And in addition, our brand new hospital, the Arima General Hospital, is also poised to hold. It has CT machines, MRI, and radiological and my apologies, blood gas machines, and ICU with a range of medical equipment. We also have the Coover Hospital that has MRI machine, CT, and medical equipment. So we are at a positive stage as it relates to medical equipment. As it relates to backlog radiological responses, what we have done, our strategy is we have taken those that might have been a backlog at the Aquila Medical Sciences Complex and we have sent it to Arima General and Coover. So that has brought down our backlog. And in relation to staffing, what we have done is that we have done continuous audits through quality improvement audits, and we have looked at all our clinical needs and management need, and we continued schedule training.
Blake?
Thanks again, Chair. Let me just start with the waiting times at A&E. So the Northwest Regional Health Authority has a specific problem with waiting times at A&E, and I want to acknowledge that from the onset. But that problem would have prevented itself once the central block at Port of Spain General Hospital was condemned and demolished. We went from having over 500, almost 600 beds at the Port of Spain General Hospital to now having just over 100 beds at the hospital. It means that persons coming into A&E being triaged and seen and so on, and that waiting time to go to the ward or to be presented for a bed is always extended, because now Port of Spain General Hospital is always filled. There is never an empty bed at Port of Spain General Hospital, so it's almost like you're waiting in A&E for someone to be discharged to get a bed in the hospital. What have we done since then? Well, obviously we have 540 additional beds that will be commissioned at the end of March next year when the central block comes on board. But to alleviate some of that stress, the ministry has assisted us by providing funding at the St. James Medical Complex to open a 60-bed unit, which we opened during COVID-19, which is used now to refer low acuity patients from Port of Spain to move them from the wards in Port of Spain to St. James to free up bed space. So we are going to have some limitations between now and March next year based on the limited bed space, and that will affect the transition and the patient journey from that triage in A&E onto the wards and so on. In terms of the major medical equipment, I spoke about some of it earlier, but I want to say we would have commissioned a new radiology suite at the Port of Spain General Hospital last year, which includes new CT machine, digital X-ray, mammography, and so on, and that has been working well. The existing accident and emergency, we do have portable X-rays and a digital X-ray machine there. Just 2 months ago, we have commissioned a new MRI at the St. James Medical Complex, and that has assisted us greatly. One of the things that we've done to alleviate critical needs for MRI and emergency needs, we have a referral agreement with at least 2 of the major providers nationally for MRI. So we have a referral pathway that we send critical MRIs to the private sector too also.
Benakit.
What measures are in place to prevent doctors from redirecting patients to their private practice when procedures can be done at public institutions?
I don't know if the PS or the CMO wants to deal with that. That issue came up several times at almost every town hall meeting where patients indicated, either formally or informally, they were told, get right now here, but you can check me down the road.
At considerable expense to them.
Thank you, Chair. So yeah, that we've also gotten that complaint from our clients with respect to doctors that practice. So I know.
What's the official policy on that?
It shouldn't be done. The patients are treated at the public system. That is the official policy. It's as simple as that. But let me let the respective CEOs speak to what they've done in their individual RHs and facilities with respect to that particular practice.
So let me interject. So you're saying it's not official policy. That cannot be done. It's not supposed to be done. But it was a widespread complaint. That's what we were saying. It was a widespread complaint.
And I acknowledge that, member, but it is not the policy of the Ministry or the RHAs for patients to be referred to the doctor's private practice. That is not the policy.
Can Dr. Armour identify what has been done to minimize or eliminate that? First of all, is it something that you acknowledge is happening at your RHA?
Yes. So at the RHA, we have a attempted policy approach. It's a conflict of interest, and the short answer is no. So it's a conflict of interest, and there's also to the public-private practice dynamic that would have come up in previous commissions of inquiry into the health sector. That was a point for national discussion. What we do now in the current reality is that we internally alert staff on a daily basis what tests are available and not available, and we are going one step further with the corporate communications department to also put up public notices, particularly in emergency departments, to indicate by exception this test is not available. Majority of our equipment are uptime or up and running, so only in the instance it is not running, we would put that up as a notice so the public is aware. Moving forward, we also have a system. If a test perchance is not available, it is supposed to be escalated by the doctor to the head of the department, and then we have our medical chief of staff and director of health, because the Ministry of Health has indicated that we do have the autonomy we are required in order to outsource tests in the event it is not done in public.
So I'm loath to interrupt you. Member Naked asked what was being done, and your PS directed the question to the heads of the RHAs. And you acknowledge, and I'm presuming the other RHA heads acknowledge, that this is a complaint they've had, that patients are being redirected from the public healthcare sectors by doctors and other professionals to private healthcare sectors. So the question wasn't about what's available. The question is, now that we've acknowledged it is happening, what is being done to minimize or eliminate it? And if you have identified doctors who are engaging in that practice, what happens to them? Because the PS indicated it is not policy, it is frowned upon. What is being done? Have you identified doctors or other professionals who are engaging in this practice, and what has been done?
In terms of identifying doctors that engage in the practice, we have to depend, like in any system, the patient has to validate a complaint to the quality department, and then that has to be investigated. Some patients, honestly, are afraid or they have a fear of being victimized, so they do not put the formal complaint forward. Also, we are looking at our own internal security department in order to determine if there can be operations to unmask this phenomenon. So it is something that is not that simple or easy, because you have to have evidence in order to take consequence management against employees who are found to do this practice. So therefore, that is why what is being done is to ensure that everyone has the same information. The staff has it, the patient has what tests are available, because we find a little more unfortunate reality where tests are indeed available, but persons are still telling patients that the tests are not there. Because when you have uptime of equipment and the majority of your tests are available, then that is a different paradigm. And therefore, what we are realizing is that despite what is being said, tests are indeed being available. Also, to another finer dynamic is that the tests are done, but there may be delays in terms of from the test being read and the report being available. That is what we are also looking at, so that if you do a test, rather than the doctor tell the person, well, you know, if it did the test and it's not available, or that they may not do the test because they believe it will take long for us to get the results, that is what we are also looking at. So we are setting metrics to state, if you do test A, B, or C, it is going to be ensured that you will get it within 2 weeks. If you don't get it, alert us. And therefore, those are the systems that we're doing to increase the accountability and to reduce that phenomena. But yes, there is need for a national discussion, as I said, based on previous commissions of inquiry, to address this public-private practice conflict of interest.
In the interest of the public, just let me break it down a little bit for you. I understand all what you said. Let's say we have a brave patient who came forward and made that complaint, identify the doctor. What is the systemic repercussions of that? What kicks into place for us to have some justice for the public?
What kicks into place is that that complaint will be taken, it will be investigated, and therefore, if it is by the quality department to do a quality investigative report, plus or minus maybe security as well, and therefore, once you have an investigative report, the case to answer, then it goes through our RHA Code of Conduct mechanism, because you are expected to perform your duties diligently, and therefore there are matters within your control that you choose to willfully not perform your duty in terms of offering the patient the service or informing the patient the service was available. So there can be consequence management through the Code of Conduct, disciplinary tribunals, what have you, as the case may be. If it is anything that is criminal, we refer the matter to the police.
So give just for the benefit of the public again, and for us, how many cases have you prosecuted in this manner, given the widespread complaints that we've had on this topic?
None.
None.
Well,
whoever it relates to. Okay, Chair.
You got anything, please?
To the CM?
No.
None. Zero.
Yeah, non-zero, but the thing is that we have not gotten, even though we have not gotten that level, we know it happens, but persons have to come forward, and that is the issue. So therefore, the actual registering of the complaints, but your scenario was in the case of if somebody is brave to come forward and write, what do we do? So that's what we would do.
And you remind me of something. You said they might be afraid. Afraid of whom? Of whom? Of what institution? What could possibly happen? I don't understand that. I didn't understand that at all.
Well, persons who are ill, they are vulnerable, and therefore they are dependent on the physician to administer the level of care that they need. So therefore, there would be fears that there would be a compromise or compromise of the doctor-patient relationship in that regard. So therefore, persons would come there, maybe encouraged to report.
Dr. What that is a frightening phenomenon that you're putting into the public domain about the possibility, I'm saying possibility, that persons who feel they have a quality issue with the level of care they're getting in the public health sector, and I'm not saying it's not true, are fearful of victimization. And I guess you're talking from your Southwest Regional Health Authority. Can the PS or any other RHA head indicate if they have had any complaints about that issue where doctors are referring, well, let me not say doctors, but professionals are referring patients to private healthcare institutions, because it is something, yes, it's a national issue that has come up with commissions time and time again, but for some reason, this country seems not to want to deal with it. And it has come up over and over in our town hall meetings and is a serious issue facing the healthcare sector that I think at some point we have to deal with.
Chair, so I'll let the CEOs respond, but just want to clarify one thing with Southwest. I know Member Naki would have asked how many cases have been prosecuted, and the answer is 0. But I just want to get clarity from Dr. Amo. How many complaints have you received?
That I'll have to get back to the committee, but in my memory, the answer is not not within recent time, at least not within my 5-year tenure so far, that have had recorded complaints of such nature.
Have the other, Mohit, but have the other RHA heads received any such complaints?
Thanks, Dr. Richards. So yes, I have actually received written complaints. The PS would have received a complaint from a member of the public. It was passed to me as CEO, while I wouldn't want to speak about the specific incident, but it dealt with surgery at the hospital and the patient being referred to a private institution and so on. And the ministry would have asked me to investigate same. I would have appointed, based on the RHA conduct regs, an investigator and so on, and going through the due diligence process where that is concerned. So yes, it is a phenomenon that we are seeing and have seen. So it's twofold really. What you want to do is say and emphasize to the clinical team, the physicians and others at the hospital, that this is misconduct. There's no ambiguity where that is concerned. To let them know, based on the conduct regs, this is a conflict of interest and it is misconduct. And we've done that in terms of going back to the physicians and having that hard conversation. In fact, at a meeting, the PS and CMO would have shared that we were at North Central. We would have spoken to a number of the surgeons in particular about this specific issue. The other thing, and I just want to give Brian a little bit of support here, is that we need members of the public to put things in writing, because information is not evidence. And while the quality department may get some information, it becomes my word against your word. If we have something, if we have a submission in writing, there's a process based on the disciplinary code of conduct and the RHA, because now we have some evidence to investigate.
Speaking of evidence, the other limb to this phenomenon is, in addition to the patients or the clients making the reports, what we've also had anecdotally is that while doctors or professionals are supposed to be on duty in the public healthcare sector, they clock in and they go about their private business. That's also part of the phenomenon. Is that something of concern to you, goodly people? Because that one, you have more administrative control where evidence is concerned, and more, to me, responsibility for. Is that something that has occurred, or you're actually pursuing or investigating or examining or monitoring? Because that's another part of the issue.
So I will start again, Dr. Richards, and yes, of course, that is something of grave concern to us. And we spoke a little earlier about persons understanding their role as managers at the executive level and as middle managers. So we find now that persons in the hospital setting must manage those persons under them. Everybody in a hospital is rostered to work a particular duty and so on. In the hospital system, we have something called a returner personnel, where the finance and HR department will look monthly at a person's attendance and punctuality, and that needs not to be a rubber stamping exercise. Department heads must take really control of that and ownership of that. So in the learning and education that we've done with our middle management is something that we continue to emphasize, but it is an issue, it is a problem, and we are working on it.
Member Beckles.
Can I ask a follow-up from Member Naked's question? I just want to be clear. Is there a disciplinary code that specifically states to the doctors that they cannot offer to a patient their private practice?
Truly, I'll attempt to answer. The short answer is no. Based on collective agreements for doctors' contracts, junior doctors are prohibited from engaging in private practice, specifically from the hours of 8 a.m. to 4 p.m. In the RHA Code of Conduct in the law, there's no specific provision that says it's a misconduct to do so. And then we also have to put into context that at the senior doctor's level, there is a relative dearth of specialists. So therefore, you do find that there's a demand both in the public and private health sector for limited specialty skill sets that only few nationals or few persons employed could provide. So therefore, for senior doctors in the collective agreement, there's no specific requirement to specifically to provide a full 40-hour work week based on their specialty skills, and that is something way back.
Sorry. But that's different from the question member asked. You stated before, we know that what is a problem ahead of us. She asked about the disciplinary code. You said there is none. So then what are you going to investigate if somebody makes a complaint? How are you going to investigate? There's no disciplinary code in place.
Sure.
So what you're doing is useless.
Can I?
Yes.
Through you, Chair.
Yes.
So, both years would have referred to the RHA Code of Conduct regulations, so which is similar to what exists in the public service. So it will not, and just on Beckel's question, that would not specify the specific possible infraction, so to speak. It would speak about possible misconduct, and that what needs to happen is that the RHAs would have written to the respective, as from a policy perspective, some policy guidelines, and those are what the doctor or any other professional may be in contravention of. So when Brian spoke about the regulations not being specific, it's not, and it will not be. It cannot be that prescriptive to list every infraction in the regulations. It would speak to something, and I'm just using an example, to bring the service into disrepute, for example. All right, so it's that broad. But the respective policy guidelines issued by, I guess, the Director of Health, and CEO Blake spoke about the management in the respective hospitals and authorities, would speak to these are your obligations as a clinician, as a nurse, as a technician, what have you. And if you're in breach of those guidelines, and that's where the disciplinary process kicks in the regulations. I'm not sure if I cleared it up.
Can I just ask one more
Yes.
question? Okay, so that following on Member Naked, if you, based on your evidence, you have not been able to prosecute anyone, have you formed the view that there is an issue as it relates to patients, having to go to someone's private practice or hospital? Okay? Have you formed the view that there is a problem? And are you satisfied that the present rules of conduct, the disciplinary code, addresses that matter? If you say no to that, are you doing anything?
Thank you. Through you, Chair. So, CEO Blake would have mentioned there was one formal report that we got, written report, and I think that matter is still under investigation. So the process is not completed. It is still being investigated, if I'm not mistaken. So I don't think we can say that it doesn't work. It is actually on the way as we speak. I'm not sure, if I may, to ask the other two RHs if they have
Yes, please.
any reports of such.
And just before we go to the other two RHAs, are medical healthcare professionals required to disclose to the RHAs or the Ministry of Health if they are engaged in dual roles? Are they required to say, well, yes, I'm working for the public health sector, but I also have a private practice, so I practice elsewhere? Are they required to disclose that?
I don't think they are, Chair. I'm subject to correction. I need to look at what their employment contract with the respective RHAs speak to. Mm-hmm. Yeah. But.
All right, boat phenomenon, yes, I know that I've heard of it existing, but it has not really reared its head at the Eastern RHA. Should we be given any reports? Of course, the consequent management training and so on that we have in place, just to back up a little bit, our doctors are fully aware that this is forbidden, you are not supposed to do it. We have run and continue to run consequent management training, so they are aware of, should they bring the authority into disrepute, what can happen in a case like that. At the Eastern RHA, we also ensure that through our management structure that we always advise and inform the doctors of that this is forbidden, but it's not something that has really been seen in the Eastern RHA. But should it be seen, we do have systems in place to deal with it.
Mrs. Thomas Lewis.
Yes, Chair. At this time, I don't have that information available, but what I can share with the committee is that clinical governance is paramount through our medical chief of staff. As such, all our clinics and operating theatre times are held, and this is monitored both through the Office of the Chief Medical MCOS and our DOH. So no clinics are cancelled, no theatres cancelled. We have daily dashboards and that we would work with as well. We work closely with our medical records department so that before the operating theatre and clinics are held, these things the patient list is going through. The day after, we also do a reconciliation of all the theatre time and the clinics that were held. So the NCRHU would, after the clinics, would conduct telemedicine checkups during the clinic and your next clinic day to ensure that the patients are well. This is what is done.
Just before we go to Member Nackett for his final topic in this round, and then Member Beckles, I have to tell you, and this is my opinion, anecdotally, I don't get a sense that this phenomenon of doctors potentially, or medical healthcare professionals potentially compromising the system by this referencing to referral to their private practices or hospitals is something that is being pursued as vigorously as it should, based on the feedback that we've gotten in our interfaces with the public, because it seems from what we've gotten, and that's just a snapshot we are aware, it is a widespread practice that the public is very, very disturbed about. So my suggestion is that some sort of formal investigation be done to gather some data on this in a really formal and profound manner to see if it is happening as widespread as it seems to be based on our feedback, so that more definitive consequences may emerge. Because based on Member Beckles' question, Member Nackett's question, I don't know what the consequence is going to be, even if you investigate it, because the consequences, bringing the RHA into disrepute, that's a whole legal long case there. You understand? With no potential definitive outcomes based on what we've heard. Member Nackett?
Chair, just want to make a comment, if I may. So, accept everything that you just said. We will look at a formal investigation, but I want to just bear in mind what Acting CEO North Central just said. That speaks to looking at the process. So while we have a lot of anecdotal mentions of referrals to the private sector, as the CEOs have said, we have very little written complaints coming to us that we can actually investigate. So barring getting those written complaints, which we would love to get and investigate and treat with, we have to do what you just spoke about, which is to look at the system itself, and that's what Stacey spoke to. And maybe it wasn't that clear, but that's what is done, and that is what is done at the respective RHAs. Obviously, that is not that easy, because it speaks to looking at every clinic, and what did the patient come in for? Were they referred for a surgery? What's the wait time? What's happening with that person? That is a lot to go through. It's being done. It's not being done 100% as we speak. Something in progress. But if we have,
I'll make what may be a controversial statement before I go to Member Nackett. We may have whistleblower legislation in the books soon. Member Nackett.
okay.
Yeah, just remark on what you said. On the ground, the problem with these written submissions for people giving evidence, that is a problem in itself. You do not know the people on the ground. Some of them who go in, especially NCDs, once you tell them write their complaint, they're gone. They can't. Some of them can't. What you should have is a system in place where people can make an oral complaint and somebody writes it for them and signs it. I mean, there's so many things that can fill those gaps you all are talking about. Okay? Anyway.
Through you, Chair, we do have that in place. That's where the quality departments come in, where people can make complaints there. So that does exist.
Thank you.
Mr. Chair, before we move on, you are saying people can make complaints. You are now saying to persons here in this meeting that, we encourage people to make complaints. You are telling us monitoring and evaluation takes place. Quality control takes place. But members of the public are not aware that they can make these complaints. From our general discussions with persons at these town hall meetings, persons are just simply not aware. They get this referral paper, they want their surgery to deal with the shortcomings of the RHAs. Maybe, I'm not sure if it's not being looked at because these private doctors who have their private practices kind of take the how you say it, what horse of the, usually, they take the problem away from you. When they get a referral, they go to the private doctor, get their surgeries done, get their testing done, and they no longer come back to the public health care institutions. So I'm not sure if it's because of that, but persons are not aware that they can make complaints. First, maybe they are not even aware that they can do a complaint in writing. You are saying that persons may be victimized or afraid, and you are telling us, CEOs respectfully, that we encourage people to put things in writing. So on one hand, you're hearing that you can be victimized, and on the other hand, you're hearing write a complaint. So if you write a complaint, you're not going to be victimized. So these are the questions on members of the public, their minds. So you have to encourage persons via public awareness. What do you have in place for that?
Thank you, Member through the Chair. So I take that on board in terms of, are we sensitizing our clients sufficiently? The RHs could speak to that as what is done on the ground at the respective hospitals. Are the CSRs out there advising patients? But I think, and I said it at the start, that's what this is for also. We take this opportunity at this committee hearing to share that information because people listen. So
thank you, and I appreciate that. What you can tell by this exchange on this particular topic, because every member has asked some probing questions about it because it has come up over and over again. So it may be some feedback to you that something needs to be more vigorously pursued. Member Nackett and then Member Beckles.
Another major complaint we had was the access to medication, especially when it comes to deals with the treatment of prostate cancer. Avodart, Flomax, a lot of people said that they couldn't have access to those. Is there a low supply of those drugs?
Chair, if I may, I'll let my principal pharmacist speak to the issue of pharmaceuticals.
Good morning. Thank you very much. So with respect to those two items, from time to time you would have a reduction in supply. However, those items are basically at the secondary care system, meaning the hospitals and certain district health facilities. It will not be at all health centers. And therefore, in some instances, clients may not get it. They may think that they get a prescription from the hospital. I'm just bringing some context to what probably would be. So they would have gotten a prescription, let's say, from a hospital, and they would obviously think that they can go to any health center and collect the medication. But because these are specialist medicines, they'll be available at particular general hospitals and the district health facilities, which is a hybrid between a health center and the hospitals. But I do acknowledge the fact from time to time there may be limited supplies, so it doesn't mean that it's completely out of stock in the country, but it may be available at another institution. And what we are doing at the ministry together with the RHAs is bringing some in terms of a system where there can be visibility from one RHA to the other RHA so that patients can be informed as to where they can get the supply. So I'm thinking that should, is that okay? Yeah.
That's fine.
Thank you. Member Beckles.
Okay, I know that, time is of the essence, so I'm going to ask 3 questions, and it really relates to the Minister of Finance during the Standing Finance Committee talk about challenges with the sustainability of the CDAP program. So the first one really has to do is what has been the main challenges with the delivery and continuation of the CDAP program. Okay, what has been the main challenges and delivery and continuation of the CDAP program? The second one, how is the success? How do you measure the success of the program? And considering this, how successful would you rate the current iteration of CDAP? And the third one, which is linked, is have you done an assessment of the program since it started? And if the answer to that is yes, what have been the key findings? Okay, so challenges, measurement, and if you have done any assessment. Thank you.
Thank you, Chair. Through you. Maybe I'll let CMO take it and I'll jump in if I need to.
Yeah, just for clarification. So the CDAP program was started many years ago, and the premise of it is really to increase the access to diseases related to specific types of illnesses, for example, diabetes, hypertension, chronic diseases, into a wide network that utilizes somewhat of a public-private partnership where the CDAP is actually distributed from private pharmacies as in addition to our distribution within the public system. So that's where CDAP came into being many, many years ago. And there would have been, a lot less public health institutions at that time when it started. So it expanded greatly the network of delivery sites so that people could access those medications. In that general sense, I think the CDAP program, before the principal pharmacist goes into detail, continues to have a role because there's a much wider network, and in terms of the hours of operation of the private pharmacies, there's access beyond hours, Saturdays, Sundays. So the access to CDAP drugs is greater with the network as it exists. So Ms. Sibu could expand into the actual questions given that context.
Thank you very much. Thank you, Chair. So with respect to, just to get at 3 clear questions, it's challenges with respect to the delivery of CDAP, and in terms of measuring the success of the program and the assessment in terms of the current iteration. So with respect to the assessment, if I can go in the order, any order. So with respect to the assessment, it started in February of 2003. There would have been assessment within 2003 itself, and therefore, because it started with over 65, the assessment based on the acceptability of the program itself, at the end of 2003, it is where it was expanded for all, access to all. So in terms of assessing very quickly, fast track to 2024, there would have been further assessments of the program where we would have included other disease states in terms of, it started with 8 disease states that we were treating. It's now 11 disease states. And there would be, again, with the further assessment, which is currently underway, we are looking at probably expanding the amount of, or the type of medicines, or the amount of medicines, the availability of items on the CDAP listing. The most current one would have been in 2019 with respect to our HEARTS initiative, which is the management of hypertension in the primary healthcare setting, and the addition of one particular item onto the CDAP program. So that's in terms of the assessment and the acceptability by the members of the public. The ministry did take a review and assessment of the program in terms of expanding the program. The measures, the success would be the amount of clients who usually access the program in terms of how we measure. And at this point in time, I can safely say, that we do have, to date so far for this year, approximately 87,000 clients who would have accessed the service for the year 2024 to date. We have approximately 186,000 clients who would have been registered per se on the CDAP program. So those are the ways in which we measure the success of the program in terms of the measurement of the success. Challenges with the delivery of the CDAP, of course, from the inception, we would have had challenges because it was a first time going into the public-private partnership with respect to having clients access the service and access medicines to treat their particular NCDs. What would have happened, it would have looked at our delivery service in terms of the amount of pharmacies and the reach to the clients who we would like to reach, the members of the public. So we would have increased and encouraged pharmacies to be able to come onto the CDAP program to be able to provide that service for the members of the public. Secondly, our delivery to the pharmacies, which would be through a contracted service, we would have looked at mechanisms by which we would increase and improve that service to be able to get medicines out of our central stores to these far-reaching areas, and we would have increased the schedules. In addition, the supply in terms of how they would order, normally they would have been given the option of just ordering once a month. What we would have looked at is in terms of the amount of stockouts that we would have had in the CDAP program, and what we would have done is increase the amount of times that they can order the medicines, giving them the ability to order supplemental. So they would have the big order for the month, and if there's anything that is running out in a particular pharmacy, they can do a supplemental order. In addition, what we've also done is we've given the CDAP monitors the ability to redirect stock, because we do have visibility of the pharmacies and the stock that the pharmacies that they have currently. So where there is any shortfall within the active system, the monitors do have the ability to move stock around, of course, with the necessary paperwork. So that those are some of the things that we would have done. In addition, with respect to clients accessing the service, initially it started where they would go with the CDAP forms, the particular pharmacy that they were registered in only. Now the system is in such a way that you can access it at any pharmacy in Trinidad and Tobago. You don't necessarily have to go back to that particular pharmacy where you were initially registered, save and except the ones for the glucose testing strips, because they have to go to the specific pharmacies because it's a consumption data that we use for that. So that's the only one. Other than that, all other medication, the members of the public, once you're registered on the CDAP program, you can access your medicines at any pharmacy in Trinidad and Tobago. And thank you. I don't know if that would have answered all of your questions.
Well, Jess, your view still, I'm grateful for you. You've given a lot. The critical thing, I think, for the public is the sustainable issue. So I don't know if anybody can address that point.
If I may, Chair, through you. So that's something that, as we said, we're actually looking to undertake a review of CDAP to look at, Ms. Sibu mentioned what type of drugs, whether we're going to add new drugs for new conditions, look at the existing drugs, look at the population beneficiary perspective. So it's an assessment we have to do. So it's I don't think we'll be able to comment on that at this point, member.
Well, could you contextualize what that sustainability entails? Is it cost, a combination of cost, accessing the drugs? CMO spoke at the start of our interface about increasing numbers of persons seeking medical care for NCDs, a continuously increased load, or combination of all those things, which will impact sustainability of this?
Thank you, Chair. So, short answer, yes. It speaks to cost, obviously. It speaks to accessibility. CMO spoke about it. We do have additional health facilities, but you also have the pharmacies across the country where it's available. So it's really cost, accessibility. Those are the two main factors you're going to be looking at.
Your colleague spoke to 186,000 people registered. Are those 186,000 accessing CDAP drugs or just registered? And how often do you update that listing of persons accessing? Because life means people will pass. And are there checks and balances for persons who are on the list and may have passed on to be taken off the list and the list upgraded regularly so that there's a current understanding of the data that you're working with, the population data pool you're working with? And also added to that, you mentioned 11 diseases. Are there particular drugs that are obviously in more demand than others and proving more difficult to access for clients?
Sure. So I'll let Ms. Sibu answer those questions, if I may.
Yeah, so just to discuss the sustainability issue, I know we would have taken a decision a few years ago. The CDAP pharmacies, as we said, is a private enterprise, so coming on to deliver the goods that were distributed from the NIPDEC side of it. So there's now a fee of 68,000 TT that has to be paid by the private pharmacy if you want to come onto the program. So there's that upfront fee that has to be paid, which didn't exist before. So we're talking about building sustainability into the future. There's also a change in the dispensing fee. So for each item under the CDAP, so you have 10 items on your prescription when you go to the pharmacy, there is a dispensing fee. So the pharmacist is being given a fee by the government for each item prescribed. And that used to be at the outset in the vicinity of $15 when the program had just started. It was actually reduced to $10, and it now stands at $8 per item. So looking forward at sustainability, those are two of the financial considerations we took into mind when we made those changes to the schedule. So those will impact sustainability, barring the full review. Those are things that have already been done looking towards sustainability of the program. So Ms. Sibu can go into a little more detail.
Thank you very much. So with respect to the number of clients who would have been registered on the system, yes, that was one of the main contentions. So what we would have done is have a unique identifier so that there would be no duplication, and therefore we would be able to safely say that, yes, that's the number of clients registered. However, the number of persons accessing would be a real-time information that we get. So this figure would be a real-time because of the current IT system that pulls that data with that unique identifier. So that iteration was done, I think, about 3 or 4 years ago because of the fact that we were getting duplication in the system. which would translate into pilfering, or not really pilfering, but hoarding of medicines and stockouts. So it will speak to those particular things. So we would have adjusted that in terms of the IT system, and that's one iteration. So we have a unique identifier that would have been put in place. So it's 87,050 who would have accessed the service to date. With respect to the different disease states and the items, the number of medicines or the particular items, at the inception of CDAP, what we would have done a survey from the hospital setting to determine what was the most consumed item and the ones that clients would be accessing most. And that's where that particular basket of drugs came in. Again, it still treats the same 11 disease states, but of course it will all depend on if you have more chronic disease as opposed to more arthritic types of clients accessing the service. But that being said, it remains the same basket. So from time to time, you will see different pockets increase or decreases in terms of consumption, but generally it's across the board in terms of an equal amount. Thank you.
What determines, who determines, I guess, or what process determines what drugs, specific drugs for specific ailments are chosen? Because we've had feedback also from the public about the side effects, the significant side effects of some of what they describe as the generic drugs. And I can't confirm this, but this is the feedback that we got at several of the town hall meetings. And also, has there been an increase in the cost of drugs in the last couple of years that is also impacting sustainability? There's an anecdotal conversation in the public domain about the coalescing of private pharmaceutical companies that the public sector may be competing with to access drugs internationally that may have driven up the cost of drugs. Is that something that you're being faced with also?
Thank you very much, Chair. So with respect, just to understand, the drugs that are available, the basket of drugs that are available via the CDAP program, it will be the same. It's a subset of what we buy for the public health sector. So it goes through the same tender evaluation process. So it will just be the same subset. So the complaint or the response with respect to the side effects that they're getting, it's no different from what you would get from the public sector. I want to state categorically that all of the drugs that the Ministry of Health would procure for the public health sector has to be coming from a WHO-approved lab. And in terms of the registration process, we are very strong-willed with respect to that. So we ensure that the labs and the procurement agency and the procurement requirements are all within the legal requirements of the country. So the drugs are coming from a WHO-approved lab. So in terms of the side effects, all drugs will usually have side effects. Different people as individuals will have different side effects to it. So it's no different from the set that you would get in the public sector. I'm not too sure about the second question. If you could just repeat it, sorry.
Potentially, has there been an increase in the cost to the state in recent times that may be significant and notable?
Okay, thank you very much. So, as with everything else, the cost of drugs, our evaluation process, there's a criteria, and we would look to make sure that we have the registered product as well as a cost-effective medicine. So there would have been slight increases in cost, and the cost would have been as a result of freight, because all of those will be factors that impact the cost of the medicine. So we would have had freight costs, insurance costs. Those are costs included in the logistical part of the procurement. So there would have been a slight increase, yes, in terms of the cost of medicines that has to be made available via the CDAP program. Yes?
Thank you. Member Beckles.
Right, okay, so just following up on the, so how does the ministry plan to address any shortcomings, that is, availability of any particular drug at pharmacies, challenges with procurement of drugs, of the program in its current iteration, and are there any plans to improve the system? And the other one would be, what are the medium to long-term sustainability goals proposed for the program? Of course, that is linked to your 186,000 persons, and whether based on the allocation, how it comes back still to sustainability issue. So, any comments?
So as PS suggested, remember, there is a review process that has to happen. I wouldn't want to preempt a thorough review of the program before we give an answer to that query. However, if the program doesn't exist in terms of that iteration, the drugs has to be delivered to those persons for continuity of care through another mechanism. So that's as much as I could say preemptively.
If I may, Chair, through you, I think, remember, you also asked about the shortage of drugs.
Yes.
If I'm not mistaken, I don't think we have that as a chronic challenge with CDAP, Anissa. I don't think we do, but Anissa could clarify.
Okay, but do you see any trend, in any particular drugs, or because, any shortage, or you are saying more or less that whatever is required, it's normally available?
Whatever is required is normally available as we speak to CDAP specifically here. In terms of drugs generally, there are obviously global factors at play, but with regard to CDAP,
Okay.
no.
Thank you.
Mohit.
PS, you just mentioned that you are not aware of any shortages in terms of the CDAP medication, which are usually provided for those in need. Have you received reports that persons have to journey? Someone mentioned earlier that you can go to any pharmacy now and get the medication under CDAP. In these town hall meetings, many persons would have mentioned that they have to journey even outside of their geographical location, everywhere in Trinidad and Tobago, to get their required medication. Some of them even mentioned that it's more than 6 months they have not been able to acquire or get their drugs, their CDAP medication. Have you been receiving reports such as these? And if so, what is being put in place, or what measures the ministry have put in place to deal with such reports and issues faced by those who require these drugs?
Sure, thank you. Through you, Chair. But before I let Ms. Sibu respond, just want to clarify one thing, member. In terms of access to CDAP, it is at any private pharmacy that is part of CDAP. Not every private pharmacy is a part of CDAP. That's a choice they make. So not every private pharmacy is on CDAP. I just want to clarify that one point. Sure. Anissa?
We are aware of that, PS, but I'm speaking to pharmacies who provide CDAP medication. Even at the RHAs, some of them were mentioning problems to get the medication provided at the RHAs as well.
Thank you very much. Thanks. So with respect to the drugs that they're speaking about, I just want to make sure that it's the basket of drugs, because there's a limited basket of 52 items that you get via the CDAP program. So even if they get a prescription at the hospital, it might be for something that is not on the CDAP program. So once a complaint comes to the attention to my office or the office of the CMO, what usually happens, because I can tell you that we do get from time to time, we do get, coming through our CorpCom unit, we will get complaints once or twice if this item not available. Normally, because NIPDEC runs the CDAP program or undertakes the CDAP program on behalf of the Ministry of Health, it's forwarded directly to the CDAP component, the unit of NIPDEC for resolution. I myself follow up personally, because I will call to find out if the problem would have been resolved, and therefore that it usually happens, and that's the mechanism we use. So it goes back to NIPDEC, CDAP, they handle it because they have access to every pharmacy, they have visibility of the stock at every pharmacy that's registered under the CDAP program.
Additionally, so you have pharmacies who give to patients CDAP medication, but they also have the same medication for sale at their pharmacy. How do you deal with that particular issue, which was also an issue mentioned by persons who require CDAP medication, that it's not available under CDAP at these pharmacies, but the pharmacies have it available for sale to these very said patients? Have you received those complaints, and how are you also dealing with that?
I think you also mentioned that there was hoarding in some instances, which may relate to Mohit's question, because there may be a few unscrupulous people like in any other sector.
Thank you very much, Chair. So as mentioned, with respect to the hoarding, what we would have done is develop the unique identifier. So if you go to, let's say, Superfarm in Diego Martin, and you do your access your CDAP medicines, and for some reason you try to go to, let's say, Massey in St. Anne's, the system would not allow you to dispense any further medicines because you would have gotten your full supply. So that's one iteration that happened with the CDAP program that reduced, in most cases, the hoarding, that particular part of the hoarding. With respect to Member Mohit's question, we have to understand that the items, the products that the ministry or NIPDEC procures on behalf of the ministry for the public sector is the same item, they are same items available for the private sector purchase. So therefore, it may be the same item, but we try to maintain batches separate and apart so we can identify. The CDAP program do have monitors that go from time to time. So if a complaint comes to us with respect to that, the monitors will go. But what I'm saying is that we have to, I know, like I said, like CMO would have mentioned, we are reassessing the program again based on the little complaints that we are getting coming to our attention. And that's one of the areas that we are looking at in order to, so if we have, and again, we asking the clients, please submit your complaints so we can investigate further and we can bring some sort of resolution or do something with the program that would be able to give us a better ability to provide that service to the system. But it's the same basket of drugs that's available in the private sector for sale.
But I think what they have done is use the Parliament town hall meetings to proffer those complaints. And that's what we're bringing to you now. They may not come directly for several different reasons as outlined before, but they've used these town hall meetings, and that's why we're bringing the feedback to you. These are the complaints and the concerns from the public. So asking them to bring it again is like,
so Chair, through you and to the member, if we can get the complaints confidentially at the ministry, we will certainly pass that over to NIPDEC so it can be investigated expeditiously as well. And we have in the past, once the monitors do the investigation and they find, in terms of the pharmacists being errant, there is a mechanism through the pharmacy board that can play a role as well.
Thank you. Member Mohit.
Thank you, Chair. Particularly at the Arima Town Hall meeting, it was stated that there's a batch of insulin that is about to expire and NIPDEC has not released any notice about the expiration or the recalling of the particular brand. Can you state whether you are aware and can you address this particular issue at this forum for us? And if you can also state for us what is the overall procedure for recalling or removing drugs that are in circulation as such.
Thank you very much. So I can state clearly, yes, I'm aware it's insulin R, and the expiration would have been 30th of June 2024. We do have stock available February 2025 that has gone into circulation. However, because of limited resources, we would usually ask that the clients would be able to be given the medicines. For insulin in particular, it's just 1 month. So let's just say the client came in the end of May. I'm saying they would be more than likely given the insulin because we ask for first expiry, first out. That's the mechanism that we use in terms of the dispensing and distribution. Certain items like eye drops and insulin, of course, the expectation is if we give you an insulin today and you're supposed to use it within a month, that insulin will be finished before the expiration date. The monitors as well would also recall or retain the particular batch of expired items. It's been the pharmacists are asked to place it in a separate area. The monitors will come and retrieve it from the pharmacies back to NIPDEC. That communication goes out to the pharmacists, at least the CDAP registered pharmacies, at least 3 months in advance, so that this procedure will take place and the monitors will have enough time to go to Trinidad and Tobago to retrieve all of the expired stock. And the pharmacists asked to submit their requisitions for the new stock, the unexpired stock, so that patients will get the stocks that's not expired. I have had complaints and I've brought it to the attention of NIPDEC. What happened at the time is that the monitors went in immediately. They would have warned the pharmacists. There's a procedure because it's a contract that they signed with NIPDEC on behalf of the ministry in terms of the provision of the CDAP service to the population. So we do have stock of the insulin at this point in time. The pharmacies that were errant in that sort of behavior, they were written to. And I know the monitors did go in. The complaints that I would have had from that particular area, the monitors did go into those pharmacies, and there is stock available at this point in time with 2025 expiration.
With that,
What was the quantity in that batch of expired insulin?
I can't say at this point in time, but I would probably be able to give it to you subsequently, if that's okay. Yeah.
thank you. Just to let you know that we understand that one of our other committees, chaired by the Honourable Speaker, the PAAC, will be doing an in-depth inquiry into pharmaceuticals in Trinidad and Tobago. Member Naked.
Following up on that, how does the ministry safeguard against persons selling or distributing recalled drugs? Did you all hear me? What are the safeguards in place?
Thank you very much, Chair. So with respect, once there's an item that is to be recalled, a media release goes out from the Ministry of Health to alert the public. And that being said, the public is given the necessary details in terms of where you can call or what you can do in terms of resolving the issue. In terms of safeguarding the sale of recalled items, we have the regulatory unit of the Ministry of Health that undertake inspections on a daily basis. So once those things go out, we usually go out to the pharmacies to try to retrieve or to do what we need to do from a regulatory perspective to ensure that the public is at in no harm at this point in time.
I think we saw nothing in our recent history that some pharmacies had stamped again or put a new stamp on some drugs, and so it's a couple of years ago. And I mean, how can you safeguard against these things?
I think, member, thanks. Public education and media coming out from the ministry in terms of safeguarding on what is the correct thing to do. And this is what the ministry would have attempted on several occasions. Once there's a recall and there's sensitization, I know late last year we would have sent out 2 media releases, 2 communication out to the ministry to the public, with respect to what you look for on your labels in terms of how you read your product packages, and a contact number with at the Ministry of Health where the public can call to seek further information whether a product is registered or not.
But in terms of your internal processes, because there's been a lot of reference to the Quality Control Division in each of the RHAs, the Minister of Health is on public record as stating that there are pharmacies that have been investigated for selling non-approved drugs and pharmaceuticals. So if that is happening, by extension, what Member Naked is asking about may also be happening. Have there been pharmacies who have been identified as running afoul of this?
So Chair, if I may, so I was just going to mention that point that we do have within the ministry inspectors in the Chemistry, Food and Drugs Division that do go out to the respective pharmacies. They look at, to make sure they're following the regulation, the law. They look at recalled drugs, expired drugs, registered/unregistered drugs. So where we do find breaches, the items are seized and the matter is referred to the TTPS. So if we do have instances where that occurs, that is the process that is followed.
But again, are there pharmacies that have been identified as running afoul of this practice and referred to the TTPS?
Chair, yes.
Okay, thank you. Member Naked.
Has CDAP experienced any major discrepancies regarding the eligibility of patients to receive assistance under the program or the inaccuracies in the dispensation of drugs by participating pharmacies? If so, please describe the discrepancies and your proposed strategies to counteract them.
Thank you very much. So the answer to the question is no. As would have mentioned before, because of what would have been unearthed from the inception of CDAP and the continuous assessment over time, the iteration of the IT system would have allowed for us to be able to manage those particular issues in terms of clients accessing medicines more than once within the same period of time, and in terms of issues in terms of inaccuracies of dispensing, Was that the question? I didn't.
Yeah.
Right. Good. Inaccuracies of dispensing. So the pharmacist at each pharmacy, based on the Pharmacy Board Act, you must have a pharmacist, and the pharmacist is the one responsible. That's the person who signs off the prescription and the dispensing of the prescription. So that responsibility lies solely with the pharmacist, and therefore any inaccuracies, the pharmacist is directly responsible for that. If for some reason there's something that happens, I'm speaking from a pharmacist's perspective at this point in time, normally, if it is picked up from our end in terms of the dispensing end, we contact the client, we contact the doctor. If the client has an issue, or if it is picked up by the doctor, the communication comes between the pharmacist, doctor, and the client for resolution. But as far as I'm aware, there has been no complaints or inaccuracies, and the iteration of the IT system would have allowed to treat for the multiple dispensing.
Okay. Is there any process to revise the current CDAP eligibility criteria in terms of diseases and medications covered? Or are you satisfied with it?
So, Chair, if I may, so that's part of both CMO I mentioned, remember, that we have to do that review of the CDAP, and that will be part of the review process.
We have 15 minutes and 3 sections to get through. Member
Yes, so
Beckles.
in the interest of time, this is patient record, and I'm going to give you the 3 questions. They're not really difficult. It's all about confidentiality. So how does the Ministry of Health plan to address concerns about patient confidentiality breaches and the loss of patients' medical notes due to negligence? Can each RHA briefly advise on the progress achieved, if any, in relation to the digitizing of patients' record at public healthcare institutions? And the other is, are there standard procedures and protocols across all RHAs which govern the release and or transfer of patient records to external parties?
Sure. Thank you, Chair. If I may, I'll let the RHs respond to those questions, please.
In the interest of time, if you could keep the answers as concise as possible, please. Thank you. We can start with Dr. Hamor.
The answer is yes, patient confidentiality is paramount prescribing policies. So we do have a lot of safeguard in the medical records department with respect to managing confidentiality. Similarly, with respect to review and transfer of records and even patient access record under the FOIA Act, that's prescribed with medical records and legal department. With respect to digitalization of records, we are part of the national effort that's led by the ministry, and at this time we are in the business of converting paper-based records into digital records involving equipment, scanners, personnel, and staff, and not only medical records at the core, but also having electronic access to the other aspects of care, particularly lab, radiology, pharmacy, and so forth at this time.
Is there a timeline in terms of completion of that digitization process?
We work with the Ministry of Health, so I'd like to refer to the PS because we're working under the national effort.
Okay, thank you. Mr. Blake?
Sure. So I wouldn't go over what Brian said in the interest of time, but as Brian said, it's a national effort in terms of digitization. But just to reiterate that Northwest has reached somewhere in terms of our digitization, I'd like to say very advanced in terms of that effort.
What does that mean? Very advanced is very nebulous.
So I'd qualified member. So what we'd have done in 2018, 2019, we'd have started a pilot with Newfields Technology, an international company.
20%, 40%, 60%?
No, I would say the ministry actually recently did a survey of all the RHAs, and I think in terms of the health information system development, we were at about, overall, I would say about 60%.
Okay. Mrs. Ramprasad Pierre, and then Mrs. Thomas Lewis.
All right. As Dr. Amo indicated, confidentiality is of paramount importance. The same protocols are observed at the Eastern RHA. In terms of the protocol for release of patient records, yes, there is a protocol in place for that, and it is adhered to. In terms of digitization, we are also part of the National Trust. At the Eastern RHA, we have commenced digitization of patient records specific to our accident and emergency as our first phase, and we're going to be guided by the national efforts through the Ministry of Health as we progress further with our digitization efforts.
Chairman, yes, we are very dedicated and focused on our patient confidentiality. Just as Mr. Blake indicated, we just partner with the Northwest Regional Health Authority on the Newfields Technology for patient registration and pharmacy module at the Arima General Hospital. In addition, in 2023, we introduced a Eric Wheeler Medical Sciences Complex Medical Records Patient Referral Unit, and we are proud this is working wonderfully. So we are basically 100% as it relates to digitization, utilizing in-house grown system. And we are also in the national trust as well with Ministry of Health.
This is a joke, eh? You all sound like a wonderfully rehearsed choir. But I'm not casting any aspersions. The question also, PS, and you can answer in addition to the digitization process.
Thank you, Chair.
Because I know it has been, we've received information that's an ongoing process, not only in the Ministry of Health, but other ministries. What presently occurs, because we got several persons coming forward. In one instance, I remember clearly the woman said she was asked in South, she was asking for her patient records, but she had quite a challenge in getting her own information, which to me should belong to her, right? And what's the policy on using your own information to take to private institutions on your own volition? And she got the records of a male in an unrelated ailment, and it was a disaster for her to try to get the correct records in her case and then when she went back, they could not find her records at all. And she'd been a patient for a number of years.
Thank you, Chair. So I'll let CEO Amon speak to that specific issue, but let me just touch on digitization because I know that we all spoke about it. So very briefly, the strategies, and the CEO has mentioned it. We started with the emergency department. We then roll out to the outpatient clinics and the wards at the respective hospitals, and then we roll out to your health centers. So that is very broadly the strategy. As I said, the different RHs are different stages of that where the percentage comes in, but that's the overall strategy. And then ideally, what we want to get to is the one patient, one record concept. So if you go to a hospital, let's say San Fernando Hospital, and you visit the health center in Valencia, they'll both have access to your one record. That is the ultimate endpoint.
The Minister of Health had, during the COVID-19, the heat of the COVID-19 pandemic, spoke to this digital identification card in the healthcare sector that was going to revolutionize, yada, yada, yada. Can we get an update on that? Is that something the ministry is still pursuing in terms of the digitization of records in concert with having a unique identifier perhaps for each client?
All right. So I think what you may be referring to would have been during the vaccination drive, that vaccination card. So that would have been specific to vaccination. What we do have, and as I said, that is our objective, is the one patient, one record, and also having a unique identifier for each patient. Now, I know that the Ministry of Digital Transformation is also looking at a unique ID for citizens. So whatever they come up with, we will be using the same thing. But in the interim, we will have a unique ID for a patient in the health sector. That will then dovetail and fit into the overall digitization strategy from the Ministry of Digital Transformation.
So while the digitization process is ongoing, and Mr. Blake indicated it's approximately, I guess on average, 60% across the board, what happens in the situation where a patient is unable to get his or her records, or the records cannot be found because I'm presuming all these are now paper-based, which in some instances have to go to a department to be digitized, and how is it reconciled if a patient loses his or her records? What happens then? And what may account for that? Because it seems to happen relatively regularly.
In terms of the complete loss of record, our data does not happen that frequently. What tends to happen in real time is that sometimes patients, based on their multiple chronic diseases, they may attend multiple clinics, sometimes within a short period of time. So you do have a courier system problem sometimes. If you attend a clinic today and then you attend within 2 weeks, that same file that was in the previous clinic to get across to the other clinic. So that is what digitalization is supposed to address, and also to, even with the paper-based system as is that we are cognizant of that, and therefore those complaints come to us through the quality department, and we deal with the patient one-on-one and deal with the medical records department. So that is the current reality of the situation at present.
So the Ministry of Health takes the responsibility for sending the file to the next department or next institution?
No, the particular specialty clinic, outpatient clinic. So if you have both a heart problem and a kidney problem and you go to two clinics, because it's one patient, one record, sometimes if you attend this clinic today, let's just say within 2 weeks you go to another clinic, sometimes you do have challenges like that, and that is continually being addressed. It has happened, at least under my tenure, much less frequently, but one complaint is one complaint too many, so we still look at it.
And what is the process of patients getting access to copies of their records for their own use?
The short answer is yes, they're entitled to it under if you want your entire core record under the Freedom of Information Act, you can apply for it and therefore you could get it. Otherwise,
so
if
you have to apply for your own medical information under the Freedom of Information Act, even though you have ID that says I am the person who these records pertain to?
There's a form. Chair, if I may.
I'm asking because I don't know.
No, understood. So why Brian mentioned the FOIA request? I mean, that's if you have to go that route, but you can. There is a form available at all the RHs at the Medical Records Department that the patient simply fills out to request their record. The issue of timeliness of getting the
Thank God for that answer, because the alternative identified by Dr. Armour seems a bit absurd. That I have to go through an FOI request to get my personal record. Anyway, we're just moving around. Member Mohit, Education Awareness. Thank you for the response. I appreciate it.
Thank you again, Chair. In terms of education and awareness initiatives, if you can just outline for us whether your ministry has considered implementing, let's say, school nurses with a focus on nutrition education in the school curriculum as a preventative measure, because I know CMO is very adamant on preventative measures. So if you have any responses as it relates to that, as well as the elderly population. We have seen many elderly persons attend these town hall meetings. If you can state for us what measures the ministry plan to implement regarding travel nurses and mobile health services to ensure accessibility to healthcare for those unable to travel to clinics or hospitals.
Sure, thank you. Through you, Chair. So I think there are three issues you mentioned there, member. One is the issue of the schools and what's happening in schools. I'll let CMO speak to that. The other two issues you mentioned are related in terms of the elderly and community outreach, which really speaks about district health visitors and that program, and then also, as you said, the mobile outreach, which I think I'll let the respective CEOs speak pretty briefly to those two initiatives, but I'll let CMO answer on the schools first.
Please do, because we have literally 6 minutes. We have to get out of here for another meeting coming up.
30 seconds.
So just to, I think what you're speaking of, just clarifying the travel nurses that you spoke about. I think what we call them in Trinidad, that's probably from another jurisdiction, the terminology that is. So we call them district health visitors. So they are based in each health center. There's a lead, sometimes there's more than one. And traditionally, they would go to visit persons at their homes. So, for example, someone is a shut-in. They can't really access, come out of their home to access care. The nurses actually go to the home, sometimes with physicians as well from the district health facilities, and they do their blood pressure checks, sugar checks. They carry their medications as well. So that's what I think you're alluding to in terms of the term travel nurses doesn't exist in our territory. We treat them under the banner of district health visitors. As it relates to the school health program, the Ministry of Education has, as far as I'm aware, established a school health program by way of hiring nurses in the recent past, meaning at least a few years ago. So we have been working on the Ministry of Health through its school health visitors program, which again is district health visitor led. So it's led from the primary health care level, seeks to deal with prevention at the school health level. So the school health program is a number of things. As children come to school, you get assessments, for example, in terms of development. So you'll find the school health visitor together with a number of persons will go in. They do weight, they do height, they do checks, examinations as well. And then we do school health visits for immunization to do mop-up coverage for those types of things as well. So in terms of the prevention aspect of it, we have, in the recent past, gone ahead and established some programs for school children in terms of the ages of school children. And Dr. Clapperton can go into detail as the NCD director as to what we have been doing to target the adolescents and the children, recognizing that the children are our future and will really form, the habits formed early on will, for the rest of their life, guide them as to how they should proceed in terms of diet and exercise. And really we're trying to create a movement for lifestyle change. And our fundamental status is very simple. When you're trying to create change at a population level, we keep it as simple as possible.
Dr. Clapperton, I'm going to be very unkind to you and give you 2 minutes.
Yeah, so I mean, just for her to start, I wanted to focus on the adolescents and the children, what we've been doing under the parameters of education, increasing water intake, good diets, and increasing movement.
Please, Dr. Clapperton.
Well, just to add to what CMO would have mentioned, and to bring to the fore in case a lot of persons who may not be aware that recently, and we will be looking to run this activity again within the Easter vacation across all of the regional health authorities in collaboration with the Ministry of Health, we would have had the NCD Inspector Academies for children ages 5 to 11, and the children had an opportunity during their Easter vacation to learn healthy lifestyle habits, and were given opportunities. Well, it was built on the premise of children being the agents for change, and they would have attended these camps for a period of 1 to 2 weeks, and on completion they would have graduated as NCD inspectors, and they had the opportunity to go back home. They were given sticker-fine booklets to go home and share with their friends and neighbors and even parents in instances where they found them not practicing the healthy lifestyle measures that they would have been taught, and they would have been exposed to food and nutrition, opportunities for meal preparation, gardening, and also physical activity like yoga and dance and all of these things. And they have the opportunity to share with when they go back home what they would have learned, and to even advise and issue their sticker fines for persons who are found in breach, so the adults as well.
Thank you. That's a very good initiative. Congratulations on that. And go and tell Mommy I'm not eating 2 starches today. All right. Beckles, good luck with that.
Just a quick question. In relation to dengue, on this whole issue of education, okay, so I can say as the MP for Rima, because I'm declaring my interest, I recently discovered someone who has dengue and chikungunya, as well as another one that I can't really remember. But, have you found is there an outbreak? Are we educating the population about it? Somebody died from a Rima on the matter. I do have a concern, so I just wanted to get any feedback.
We would have been conducting a series of sensitization exercises, beginning with early February, we started to do sensitizations for the clinicians as well, because having clinicians being able to recognize the symptoms and signs and the treatment very early on mitigates against the risk on a background of people presenting with viral illnesses of differential origin. So they need to know what they're dealing with. In terms of the public education, we have been launching since I think early April a source eradication campaign. So what we're trying to get to the public really is that elimination of the breeding grounds for mosquitoes and vector-borne can eliminate or prevent the outbreaks of dengue. So in terms of our national numbers, you asked about outbreaks. We had about 147 confirmed cases for the year thus far. That's for this year. As we know, dengue is endemic to the Caribbean and to Trinidad and Tobago, and has been so for a number of years. We have been hyper-endemic, meaning having a large number of cases from the period 2014 and before, where we would have had almost 6,000 cases a year in that period. Post-2016 to present, our numbers have remained very low, thankfully, so far. But we have seen outbreaks in other parts of the Caribbean region and Latin America, and we're keeping a very close eye on what is happening in Trinidad. Certainly there is an increasing number of cases. I don't know when we do our what we call epidemic curve, it doesn't go into the alarm, beyond the alarm zone as yet. It's still within the control level. But our main thrust is to really get our prevention message out there. So if you reduce your breeding grounds in and around your homes, a mosquito, Aedes aegypti, only travels about a mile in terms of radius from its breeding spot. So if we can get that control done at the local level, the community level, we can actually eradicate from the source. So that in connection with spraying when required for the adult agents can mitigate against the risk of an epidemic occurring.
All right.
Just put in a quick plug for any further education in ARIMA. I mean, I've been sort of begging, and just to link with what Chair said, because I have a case where somebody had, went and they waited the whole day at the hospital. So of course they gave up. It ended up that they did have serious, yes.
So the education is being led from insect vector control as well in terms of the local level, and the regional corporations are working with us through local government.
Member Naked, quick final question, please.
Yes. What regulatory framework is being put in place to enforce compliance with the labeling of local or imported foods as far as the high sugar content is concerned, or the bad fat content? Because it's not just fat. I understand there's no bad fat and good fat. So.
Thank you. Remember, that's through the chair. That is a discussion that's happening right now at the level of CARICOM in terms of looking at legislation with regard to packaging for food labels. So we are part of that discussion as a country.
So a discussion is taking place, but nothing has been put in.
No, that's like level of CARICOM in terms of discussing legislative changes.
So as far as the farmers are concerned, are there any incentives or support for farmers, their businesses, to transition towards a safer, more sustainable pest control methods?
Well, he seems confused, so we will put that on to the Ministry of Agriculture. Right? Thank you. I just have a quick question based on education and awareness. One of the issues that came up in many of the town hall meetings was the fact that, and this is in keeping with preventative and proactive healthcare, as Dr. Clapperton indicated. One, people, because of the long wait times, are reluctant to, in some cases, resistant to going for regular medical checks, which by the time their systems are started to deteriorate, exacerbated, it's more load on the healthcare sector. So the long wait times and the poor feedback kind of creates a cycle of deterioration, one. And two, is there a real public awareness program? Because a lot of the issues that end up clogging up the main hospitals can be remediated in the local health districts, but the public is not aware of what to go for what. So they just go to the emergency room, when if they go to the local district health centers, they can have most, if not a lot of their issues remediated. Would someone care to comment on that and what the ministry is doing to identify to the public in a real sense where to go for what to make the system more efficient quickly?
So there's a real example that has started many years ago in North Central. So I'll ask Dr. Hamid to speak about is the walk the talk, right, in Trinidad, which actually deals directly with what you're saying. So there's people who are who return frequent times to an A&E, for example, for diabetes out of control, hypertension out of control. Those are flagged, and he can tell you what is done at the primary care level, both in terms of education and outreach.
All right, so good afternoon, everyone. So basically, the North Central Regional Health Authority in the year of 2016, we had recognized the fact that we have a lot of persons in our communities who are not being reached by the healthcare system and so on. So what we did was a partnership with the religious organizations throughout our communities. We termed it Walk the Talk program. And this is where we partner with the religious organizations to meet them on their level, meet them, the congregations, do mass screenings of the congregations and so on. We have actually covered maybe about 50-something thousand persons throughout our catchment area, plus almost 500 organizations. On a regular basis, we are discovering more religious organizations. And basically what this does is bring the awareness to the population where they could access services, pick up, screen persons for diseases at their convenience and their levels and so on, and accelerate treatments or so on in terms of persons that we pick up who have deteriorating conditions and so on in the public sector. So we are actually catching a population who may not be health-seeking behavior as such, which is a big problem we have in Trinidad and Tobago. And we offering interventions and so on at that stage as well.
Is there a specific focus on men, because men are even more reluctant than women to go seek medical help because they feel they all that?
Right. So so basically, North Central Regional Health Authority also was the pioneer of something called the Men's Health Initiative, Men's Wellness Initiative, where we started this mass screening exercise at least once a year maybe about 4 years ago. Some of these exercises would have gotten thousands, up to 2,000 men showed up. And then as the subsequent ones, it became more and more and more. So this is particularly directed towards males. And it's, it's a sort of cascade effect in terms of persons, males, showing much more health-seeking behavior than usual, right?
I think it's a strong generalization to say 2,000 men is progress. We have a lot more men to get into the catchment. Quickly, 2,000 is a start. Can we just have closing comments? Thank you all.
Quick. I'll take you up on that offer in my constituency. I will definitely recommend some religious institutions.
Of course, we look forward.
Thank you. All right, could we have quick closing comments from the chairman and each of the CEOs of the regional corporation, please?
Sure.
Yes, sorry.
Thank you, Chair, members. So again, thank you very much for allowing us to share some of what we've been doing and to also bring forward some of the concerns from the stakeholders you would have interacted with. We've taken notes of it in terms of some of it private practice, the CDAP, looking at, and I particularly looked at the issue of communication, public education, and sensitization. I think that's something that, while we've been doing it, is something we have to look at doing a lot more of and to find ways of doing it. This helps, but definitely at the level of the RH and the ministry, something we definitely want to look at. So again, thank you, Chair.
Referencing of medical professionals to private institutions is something of grave concern. Dr. Amo?
Good day, Chair and members. Thank you all very much for the opportunity to be here and to address the concerns as best as we can, as stated through the town hall meetings with the general public. We take all comments seriously on board. I'd just like to remind in closing that at the Southwest Regional Health Authority, with our health centers, close to 34 primary care centers, 3 hospitals, extended care centers, and seeing about close to 500,000 encounters in primary care and about 250,000 in the hospital. It's a health ecosystem for which we fit into the national effort. So while we acknowledge that we do have the strategies and policies in place, the concerns and the benefit to patient care is a continual process improvement, so we remain committed to that effort, working with all stakeholders.
Dr. Amo, you have the most interesting speech pattern. Mr. Blake.
So, Chair and Committee, I want to say thanks very much from the Northwest Regional Health Authority, and on behalf of my colleagues, I also want to say the session today was very informative and very real as the concerns that people actually face on the ground. I want to say my team and I have not only come here today, but we've looked online at all the consultations that you all have had and have taken questions that we've seen there and some of the recommendations and have started to try to put some of them in place. So thanks again for the opportunity to be here. Yes?
Mrs. Thomas-Lewis.
Chair and Committee, the NCRH would like to thank you very much for the opportunity, and to the listening public. The NCRH with the other region will continue to engage its clients to ensure that every interaction will ensure that individual connection. I would like to thank Dr. Abdul Hamid and Dr. Kamani White for their interaction today.
Thank you, and Mrs. Rampasad Pay.
So on behalf of the Eastern RHA, Chair and members, I wish to thank you all for the opportunity given to us today to be accountable. I have noted all comments, and the Eastern RHA is committed to continuous quality improvement. And let me just take this opportunity to thank Dr. Rajiv Bagalu and Dr. Gussin for accompanying me today. And we look forward to continued partnership to ensure that we can serve our communities well.
I'd like to thank you all for coming. I know we didn't speak to everyone, and you brought your entire teams. We apologize for not having everyone contribute, but we didn't know where the conversations would go. But we appreciate you all coming here and taking time. It is greatly appreciated. And also to put on the record that although we focused on the challenges, we did get some positive feedback in many instances that we like to acknowledge and put on the record. So congratulations on your successes, because they are successes, and we hope that you continue to build on them. Thank you for being here. And to all stakeholders who participated in today's deliberations and our town hall meetings, and the support crew, the committee members, and their continued support and participation, the staff of the Office of the Parliament for your procedural and logistical support, and also to the viewing and listening audience for your comments and your attention. Thank you so much. Our meeting is now adjourned.